Let's go over SVT, characteristics to help you identify it on the ECG, common causes, and treatments. All right, so SVT or supraventricular tachycardia is also known as paroxysmal SVT because it has an abrupt onset and usually an abrupt ending. So you'll see that the rhythm is very fast, typically greater than 150 beats per minute. Your QRS complexes are very narrow. The rhythm is going to be regular. Most of the time you will not see visible P waves, and if you do see P waves on your rhythm strip, then consider sinus tachycardia. With SVT, there is an abnormal accessory pathway that bypasses the AV nodal checkpoint. The AV node acts as a gateway to allow passage of electrical impulses from the atria to the ventricles. The AV node also delays the passage of those electrical impulses to allow for complete ventricular filling before the ventricles contract. That refractory property of the AV node is absolutely essential in limiting the electrical impulses that actually reach the ventricles in order to keep our ventricular rate, aka our heart rate, in check between 60 to 100 beats per minute. So with SVT, when all that is bypassed, those ventricles are going to contract before they're completely filled. So our cardiac output is very significantly decreased. So think about signs and symptoms that you might see in your patient with a decreased cardiac output. Obviously, they're going to probably report feelings of palpitations, possibly some dizziness, some lightheadedness, and maybe even shortness of breath. By definition, any dysrhythmia that originates above the ventricles is under the umbrella term of SVT. However, in practice, AVNRT is going to be the most common SVT that we see, and it's more commonly seen in women. As far as medical treatment, we've got to find and eliminate any triggers or treat the underlying cause. Nursing intervention-wise, we're always going to remember that we're moving from least invasive interventions to most invasive interventions with SVT and with any dysrhythmia. So, assuming that your patient has SVT, they have all the characteristics presented on their ECG. However, they are considered stable, meaning that their blood pressure is stable, they're not having shortness of breath, chest pain, their mental status is intact. We're going to start off by trying vagal maneuvers. If that doesn't work, we're going to move up to adenosine. And if that doesn't work, then we're going to cardiovert. If the patient is unstable initially, we're going to go straight to electricity. So remember, unstable gets electricity. So cardioversion is going to be the first intervention for unstable patients with SVT. Hope this helps. Follow for more. Go Vols.